Okay, we'd like to invite Amanda Corley to the podium now, please. Amanda is a nurse researcher in the Critical Care Research Group at the Prince Charles Hospital in Brisbane. She has a background in intensive care nursing and is currently undertaking a PhD through Griffith University School of Nursing. Welcome, Amanda.
Thanks, Andrea, and thanks to the committee for letting me speak today and present these results. So I'm going to be talking about our interim results from a 11-site point prevalence study that we're doing into ECMO at the moment. So extracorporeal membrane oxygenation is an advanced mechanical circulatory support for patients with cardiac and respiratory failure refractory to any other treatment. It was first successfully used in humans in the early 70s, and it was really in Australia the H1N1 pandemic of 2009 that increased our usage, and since then it's sort of gone exponentially up. What we're focusing on really is the cannulae and how they're cared for, and really the success of the therapy is reliant on properly placing the cannula and then keeping them there. So the repercussions for poor securement and dressing of cannula are quite obvious. We've got large bore cannulae, around 23, 25, and Avalon's up to 31. Into very large vessels under high flows, and if they fall out, bad things happen and the results are catastrophic for the patients. So the malposition or dislodgement of a cannula is a patient safety risk, and it is very real. We conducted a survey last year, a global practice survey. We sent surveys out to 396 centres across the world to a doctor and a nurse, and we got 391 responses. We can't say, well, we sent specific instructions saying please just fill it out, but we can't absolutely say that we have captured 391 centres. But nevertheless, I think it was a good representative sample. We asked a question about whether they had experienced a malposition or dislodgement in the last 5 years leading to an adverse patient event, and 34% of the respondents identified that they had. And over a quarter of those were directly attributable to ineffective securement of the cannula itself. So we had 71 respondents who actually gave us reasons. They wanted to talk about why they had this adverse event. We gave them an opportunity to do that. So as you can see, 20 out of the 71 were directly attributable to inadequate or ineffective securement. But the ones highlighted in blue could also be attributable to, improper securement. So, it is important. And particularly in this day and age of moving our patients, waking them up firstly, so doing a wake ECMO, and moving them around. And these are some of the patients we've had in our ICU. That's our favourite Fletch down the bottom. He kept us amused. So he was a bridge to transplant and was cycling and tilt tabling and then some other patients there. So this is a safety priority for us. The other bad thing that can happen if we don't secure and dress our lines properly is infection. And these patients are already susceptible to infection. Nosocomial infection has been reported in up to 64% of patients receiving ECMO. It increases ICU and hospital length of stay. It increases ventilation and ECMO times, and it also increases mortality in paediatric patients. So this is something that we would like to prevent. As you can see, there's lots of places that bad things can come in through an intravascular device. These patients have lots of intravascular devices, and the biggest of all of intravascular devices being the ECMO cannula itself. An ECMO cannula-related infection affects 7 to 18% of patients. So widespread there seems to change and vary around regions of the world. But the incidence is wide again, between 7.1 and 17.2 episodes per 1,000 ECMO days. Now that's 10 times the amount that you would see in a sort of a CV line. So it's a big problem, and it's difficult to diagnose, which means that it's probably underreported. That's a whole other body of work that's going on to try and find some sort of reliable biomarker for these patients who are constantly inflamed and have that SIRS response because of the presence of the extracorporeal circuit. We also, the extracorporeal circuit cools them down, so we don't have an accurate temperature, feel of temperature. So it it is a problem. So we would like to develop some interventions, looking at different dressing and securement options. But first we wanted to look at what dressing and securement looked like around Australia. And the other aim of this particular point prevalence study was infection, to look at prevalence of infection. So I'm really sorry we've got no one from Adelaide. We've got the Eastern Seaboard and New Zealand. So we've got 11 sites around Australia and New Zealand. Sorry, Steph. I know, you're away. So we conducted a 12-month prospective observational point prevalence study in 11 sites, and we collected data because of the low incidence of patients undergoing ECMO. We collected data for every patient receiving ECMO during 12 predetermined data collection weeks. So we had 12 weeks during the year. It also gave it a chance for the smaller centres to be able to contribute some data as well, which was important. And as I said, this is interim, so we're hoping to have all our data wrapped up by next month-ish. So I've decided just to present this is all descriptive data, and it's mainly percentages because the data is still coming in, so it's by no means polished. So we recruited adults and paediatric centres, so you can see the mean age there. I think, interestingly, VA ECMO was most common over both adult and paediatric. Paediatric patients were a little less sedated, but the RASS scores are negative 3.5 for adults and -3 for kiddies. And the days on ECMO, that was on the study day, was a little bit longer in adults. So here, the total cannulae, 192 versus 39 for paediatrics, and we're just reporting on peripheral cannula here, so 183 adult cannulae and 25 paediatric cannulae. As you would expect, size is a little bit smaller in kids, and most frequent fem-fem in adults and femorojugular in paediatrics. So in terms of dressing practice, overwhelmingly all peripheral sites were dressed with a transparent dressing. Some had CHG or chlorhexidine impregnated into it, whether it was the tegaderm dressing with a CHG patch or the little disc that goes around the biopatch. So, but more in... sorry. I'm getting my buttons mixed up. So children had a bit more variety of how they dressed, but it was pretty standard in adults. And the days in situ, 1 to 3 days, was the most common. We also thought we'd ask about adherence to hospital dressing guidelines, and it was very. We were happy that there was some good adherence. So even if the guidelines did change, that adherence should continue. Securement practices. Interestingly, from our global survey, 93% of the world suture at the insertion site, but Australia is sort of sometimes we do, sometimes we don't. So for adults it's 50-50, but for kids they suture at the insertion site. Along circuit tubing, we also saw sutures being used, mainly in paediatrics, or more often in paediatrics, but a commercial sutureless device like a grip lock was most commonly used in adults. And the ELSO guidelines, the Extracorporeal Life Support Organisation, which is a global body, does say that we should have 2 points of securement, and most adult sites were compliant with that. Interestingly, the kids only mainly did 1 point of securement, I guess because there's less of them to secure 2. And this 1%, there was actually 2 cannulae that had no other forms of securement other than insertion site securement, which was a little scary to me. And again, compliance was pretty good to hospital guidelines. I thought I'd add this in because we did ask about transport and mobility, and because obviously moving patients around is a bit more of a risk of cannula falling out, and we don't really move our patients around a hell of a lot, to be honest. It doesn't look like it, which I thought surprising because in our unit we sort of do a lot, and I know that Alfred do, but anyway, we'll see what the final data says. So where do we go now with this information? This information will inform a planned RCT that we have coming up, and we're doing a lot more studies sort of around this, hence the long winding road. And what we want to get at the end is an optimal ECMO cannula dressing and securement package that reduces dislodgement and infection. And further to this, we've been doing some in vitro work, looking at the use of tissue adhesive to keep the cannula in situ and stop bugs. And I hope this sort of shows here, this is just off-site, so we seeded some Staph epidermidis here and it grew all the way through to the cannula. This is tissue adhesive around here, so we seeded it here and it didn't go through, it is bacteriostatic and bactericidal, and Indy, my colleague, is doing more work on the new generation. But this study here was published just recently. And this is from Indy's study, and there's a poster, number 40, if you want to go and look at it, about the tensile strength of tissue adhesive as well. And the ones with it's a bit of a busy one, sorry, it doesn't come up that well on a slide. The ones with the red, that is sutures. So we looked at tensile strength of tissue adhesive and sutures and transparent dressing. Sutures are strong, but why maybe a bit too flexible. They had a 4 centimetre give before it was broken and it was ripped from the skin. We did this on pig skin. And this is a type of glue called Glue Brand. Very strong again, same as sutures. A little less flexible, but that might actually not be a bad thing. So this is like purely speculative. This might be what our RCT looks like. We're thinking because of the low incidence of ECMO numbers that we might need to do a factorial design rather than a parallel RCT of some securement options, which may or may not be this, and some dressing options, which may or may not be these. And we're hoping to have a pilot sort of pretty well up and running by mid-next year. And if you'd like to be involved, come and talk to me, because we'd like to just pilot some different options, and we're going into the animal lab soon to get some early data on some sheep with the tissue adhesive. And I'd really like to acknowledge firstly the funders for funding our program of research, and also the people from the sites, because without them we really couldn't have done any of this, so we're very, very grateful. And it was a love job, we haven't got much money, so yeah, so thank you very much.
Thanks very much, Amanda. Sorry, go ahead. Any questions?
I apologise for this question, but what's tissue adhesive?
Well, it's basically super glue that you buy at Bunnings, but it costs much, much more because it's medical, of course. So it's a cyanoacrylate glue, which is just a super glue that is very similar to what you would buy at Bunnings. And we first started using it in the sheep lab because with the lanolin on their skin, it was very hard to keep any dressings on them. So they literally went down to Bunnings and got some tissue adhesive or super glue. So there've been medical grade cyanoacrylate glues for quite a while, and the new formulations seem to be stronger with a little bit more flexibility, and their bactericidal and bacteriostatic properties are more enhanced, the newer generation. They've got a very low water content, and it looks like we did some very rough and ready bug work, or Indy did, at Monash, and it looks like it's fungicidal as well. And seeing as Candida is a big problem in our ECMO patients, it could be, we're excited about it, but we're also very cautious. We don't want to stem that bleeding to the point where there's hematoma formation underneath in humans. So that's why we're going into the animal lab, and we'll objectively measure bleeding and hematoma in a mammal to see if we can get some early data that gives us some safety profile. Thanks.
Any further questions?
Excellent. Thanks, Amanda.